Hello, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we have the pleasure of having a renowned educator and a clinician, Dr. Sapna Patel from the MD Anderson Cancer Center. With Dr. Patel, we hope to focus on the current standard of care treatment options for cutaneous melanoma. Sapna, thank you so much for joining us today.
Thank you, Rahul Rohit. Thank you for having me.
Welcome, Sapna. To start off, we'll start with management of stage 0 and 1A, where tumor is less than 8 millimeter without ulceration. These patients undergo surgery. They are rarely seen by a medical oncologist, but when you do see them, how often do you follow up with them?
Yeah, great question. As a reminder, melanoma is the only solid tumor measured in millimeters. All other tumors are measured in centimeters. And of course, as we get through these staging, we'll see that it becomes aggressive with metastatic potential in just a millimeter worth of tumor. These are treated with wide local excision. There's a trend in the US and maybe elsewhere to consider a Mohs procedure, which is a staged surgical procedure for these. Historically, Mohs is for squamous cell and basal cells and really should not be used for melanoma. So wide local excision is still really the standard with what we call a bread loafing histopathological assessment. And if they do end up in medical oncology, the NCCN guidelines would suggest it's really a physical examination that needs to ensue. These are, it would be considered overkill to do regular radiographic surveillance for these. Maybe baseline imaging is okay, but then really you should let the clinical symptoms guide you.
Absolutely. Thank you for going over. You brought up that how a small change, even few millimeters, can upstage these patients. So moving right along with stage 1B to 2A. In this patient population, Sapna, who is getting sentinel lymph node evaluation?
Essentially, the MSLT2 trial told us that really these are the ones that need to get a sentinel lymph node. So wide local excision and sentinel lymph node for stage 1B and up melanomas is still considered the standard of care. There are some novel assays in development to try to predict sentinel lymph node positivity, but right now we don't think it replaces the traditional lymphoscintigraphy injection of a radionuclide and then retrieval of the sentinel lymph node. And truly, it bears saying that these wide local excisions are the second kind of histopathological assessment on a melanoma, the first being the biopsy specimen. But with the stage 1B to 2A, after that, when they end up in medical oncology, pretty much annual surveillance would suffice for these.
Thanks for going over that, especially when we are talking about optional sentinel lymph node biopsy evaluation. Now, moving along into stage 2B or more, where sentinel lymph node biopsy is rather mandatory. And stage 2B involves T3B, which is tumor size 2 to 4 millimeter with ulceration, or T4A more than 4 millimeter without ulceration. Choice here is observation, radiation, or immunotherapy. Now, we have seen some promising results with immunotherapy. Now, where do you see this fits in, and how much benefit are we really buying with adjuvant immunotherapy?
Yeah, so the stage 2B to 2C is on the basis of the Keynote 716 study. 3A is a small group of patients that was in the Keynote 054 study, and the Keynote 053 or the SWOG S1404 study that were pembrolizumab either versus placebo in the 054 or investigators' choice control in the S1404. So for 2B2C, the use of pembrolizumab after clear sentinel lymph node evaluation. So this wasn't omission of sentinel lymph node and at least a stage 2. It was clearly a stage 2 because of sentinel lymph node evaluation. Pembrolizumab is carrying a benefit in over placebo of about 0.65 hazard ratio. So about a 35% improvement in what we call recurrence-free survival and distant metastasis-free survival. We do not yet have overall survival data. In the stage 3A population, the small subsets from the Keynote 054 and SWOG S1404 or Keynote 053 study, It's similar. We have these hazard ratios that essentially cross 1 on the confidence interval. They were a small set of the main study. It's hard to know if you're actually deriving benefit. 3A is a population with non-ulcerated primary and a microscopic lymph node. So even back in our interferon days, this is not clearly the patient population we would have necessarily dispositioned for adjuvant therapy.
You brought up that we're waiting on OS. I feel like melanoma has been a poster child in leading immunotherapy trials. As a generalist, we're all looking forward to these OS data because a lot of our lung cancer, breast cancer studies are where we are today in melanoma, saying let's wait on the OS, and we have the PFS right now.
Right.
So, Sapna, coming back to the same patient population and talking about surveillance scans, in stage 2, NCCN gives us a little more leeway, saying you should consider scans every 3 to 12 months for first 2 years. How often do you get scans in your clinic?
Okay, so this is where it becomes a little tricky. Stage 2B has the equivalent recurrence rate of a stage 3B melanoma. So that's confusing. It's not involving the lymph nodes, but it has the similar recurrence rate as that involving the lymph nodes. So for a stage 2B, I think it's very reasonable to do maybe 3 times a year, maybe twice a year if the patient is comfortable. For stage 3A, the recurrence rate is quite low. We will often quote something along the lines of 12% 5-year melanoma specific recurrence. So if you have a 12-year recurrence or 12-year inverted melanoma specific survival, so non-survival from melanoma at 5 years, 12%, we think that that's a group, even if we reduce their risk of recurrence by 0.65, a hazard ratio 35%, something like that, it's still really just a small chance of recurrence. Meanwhile, the risk of toxicity we know far exceeds that. So for a stage 3A patient, because their risk of recurrence is inherently low, this is the population I think it's very reasonable to do twice a year. People's instinct will be that's a stage 3, let's do it 3 and 4 times a year. But remember that their recurrence rate is less than stage 2B. Now, stage 2C is very tricky. Stage 2C is ominous, and they have a worse survival than stage 2B, 3A, and 3B. Then how can that be? It's because 2C is basically a thick ulcerated melanoma, and ulceration carries its own significant prognostic value, poor prognostic value. So a stage 2C patient, I think it's very reasonable to surveil them quarterly.
Now, I know we've covered early and localized disease rather fast, but let us dive into locally advanced where medical oncology plays a pivotal role. Based on SWOG S1801 results involving pembrolizumab in perioperative setting versus adjuvant setting, can you please share how you approach stage 3B, where N1B is how stage 3B is defined, clinically detecting one node, or N1C, which is in transit, microsatellite, or satellite metastasis?
So I think if you have a patient presenting with an operable but clinically detectable, you can see it on the scan, you can see it in the office, or you can palpate it, melanoma, I think that's the time to engage with the surgeon and say, hey, listen, based on the results of this randomized phase 2 trial, S1801, shall we consider a little bit of perioperative PD-1 therapy? And that's where you can give anywhere from 1 to 3 doses. The study was designed for 3 doses with the option, if you thought you were having clinical deterioration or progression, you could give less than that and go straight to surgery, retain that operability, get that tumor out while you're hopefully priming the immune system to give you a more amplified and more diverse immune response if you leave the tumor in place for a short period.
So, Sapna, this is the same patient population that gets peri-op, you go through surgery, and now you have an option of adjuvant immunotherapy. But if the same patient is BRAF positive, your another option is BRAF MEK inhibitors. How do you choose who gets adjuvant immunotherapy versus BRAF and MEK inhibitors if there is no contraindication for immunotherapy?
Yeah, perfect question. This is where we really need to think about it. What I will stress very heavily, if a patient takes neoadjuvant immunotherapy, and for whatever reason, you want to assess what to do next on the basis of their pathology, That's a big caution sign right now. We have no evidence that you should make a determination what to do based on the pathology that comes out. The patient hasn't failed anything, they were still operable. The treatment hasn't failed just because it didn't generate a strong response. Remember, immunotherapy is not about shrinking the tumor directly. It's not tumor toxic directly. It's indirect. It takes time. Neoadjuvant perioperative therapy is a finite short course. If the tumor didn't shrink, no problem. You still probably amplified an intact immune system. So right now, I would say there is no evidence to switch after the use of neoadjuvant immunotherapy to targeted therapy. The patient has not recurred. You don't have any evidence that that immunotherapy has not done what it was intended to do, prime an immune system. So the switch I would not do. In a patient who did not take neoadjuvant immunotherapy, they have no contraindications to adjuvant, targeted, or immuno, and they're sitting in front of you. This is the situation where I would consider some real world data. We have clinical trial data that says active interventional therapy, whether it's single agent PD-1 or targeted therapy, reduces your risk of melanoma recurrence compared to placebo, compared to doing nothing, by 50% or more. Great. So we know we can do something to reduce the risk of recurrence, but which something? So if you look at real world data, there was a real world series on about 800 melanoma patients globally done, Australia, Europe, US. And it was adjuvant PD-1 patients in the real world, and it was describing patterns of recurrence. So if you look at that patient population, 3/4 of the patients who recurred, now this was a short follow-up period, so only a portion of patients had recurred, maybe like 17% of these 800. But of those 17%, 3/4 had recurred while taking their adjuvant therapy, and only 1/4 had recurred after cessation of therapy at a median of about 5.5 months after cessation. If you look at adjuvant targeted therapy, real world global series, it's the inverse. 3/4 of patients are recurring after completion of their entire year of adjuvant therapy, only 1/4 recurring while taking it. Now, the patterns of recurrence are very similar, more than 50% are distant metastasis. This is all fine, but it impacts the response to that next line, frontline metastatic treatment. So adjuvant PD-1, the only thing that's really generating a response after that is ipilimumab or ipilimumab in combination. More PD-1 alone or with some experimental interesting this or that is not doing too much. However, the response to targeted therapy is very strong. On the other hand, if you give adjuvant targeted therapy and now you're faced with a recurrence, you have every immunotherapy generating a very strong frontline response. More targeted therapy likely doesn't do anything for you, but as we'll talk about, frontline targeted therapy in the metastatic setting is not our preferred choice anyway. So this might be the scenario, adjuvant setting without perioperative immunotherapy, where targeted therapy plays a role. Standard of care, recurrence rates are quite low while taking it, and perhaps you might actually only overall survival will tell us, right? But perhaps this is the group of patients that actually will end up with an overall survival benefit if they were actually able to eliminate microscopic clones, whereas the immunotherapy is not eliminating the clones necessarily. It's trying to get your immune system activated to see those microscopic clones.
Thanks for reiterating some of the aggressive disease burden that we do see here. It is important to just stress that we have the option of perioperative immunotherapy, and if one has not received that post-surgery, if there is targeted mutation present, to rely on the targeted therapy, or immunotherapy if there is no targeted therapy present. Now, moving right along, for metastatic disease, if we have upfront BRAF mutation, now, regardless of this mutation, would you rely on Nivo-Ipi?
Okay, so this is a great question. Frontline metastatic, you have the BRAF mutation. Right now, what we think is you park that information and you still use combination immunotherapy on the basis of the DreamSeq trial and the Succumbit trial. Now, if you look at DreamSeq, there was a portion of patients, maybe 18% or so of that patient population, who had very rapid progression on immunotherapy first. Such rapid disease progression, they never made it to BRAF targeted therapy. We think that is really heartbreaking when somebody with an actionable cancer mutation never actually sees their targeted therapy, even if a bridge to get them, some benefit. So when looking at that patient population, there were a few things. That study was too stringent on the crossover. It made you wait. It made you confirm progression. You had to wash out. So we wouldn't do that in the real world. In the real world, if you think you have somebody rapidly progressing, you switch them quickly. You do not have to wait to week 12. If at week 6 you don't like it, you switch them. On the other hand, what you might use is that baseline LDH. Some subset analysis from the SACOMBIT study, which was targeted therapy first, switching to Ipi-Nivo at disease progression, Ipi-Nivo switching to targeted therapy at disease progression, or targeted therapy with a planned duration of 8 weeks and a forced switch to Ipi-Nivo, and then a switch at disease progression back to the targeted therapy. That sandwich arm, that so-called sandwich arm, looked to do fairly well, almost equivalent to the immunotherapy first arm, and it looks to be doing even better in progression-free survival and overall survival in the elevated LDH baseline group. So if you're checking LDH routinely on your patient, frontline metastatic, they have a BRAF mutation, and you do not like the look of that LDH because it's over upper limit, you can consider a short course of BRAF MEK with a forced switch. Now, with a couple of caveats, SACOMBIT said 8 weeks and then switch. For a lot of biological reasons, that might be too long BRAF therapy. And so in the real world, based on some data that came out of Harvard a decade ago, it may be more like 1 to 2 weeks. Get that BRAF in there to block that oncogene and then switch them to the Ipi-Nivo as long as you have no tolerance issues. Take that BRAF MEK away, keep them on Ipi-Nivo until disease progression, and then do the switch over to targeted therapy.
Perfect. And for our listeners, we've covered this post-ESMO when this was all hot off the press with Dr. Sapna Patel. So go back to that discussion. So to reiterate, if LDH is elevated and you have BRAF mutation, this is the right patient to consider BRAF MEK inhibitor for a short period before we switch them to Ipi-Nivo. Sapna, coming back to Ipi-Nivo, the dose of Ipi.
Yeah.
Is 1 mg per kg the way to go, or a higher dose, what we've seen in older melanoma studies?
Yeah, original Checkmate 067 is 3 milligrams per kilogram. You take it for 4 induction doses, so you get a total dose of 12 milligrams per kilogram. If you use the low dose 1 milligram per kilogram of Ipi for 4 doses, you're getting 4 milligrams of Ipi. That's 25% of the dose. There are certain scenarios where we think that might not be good enough. Brain metastasis, mucosal melanoma, uveal melanoma. The other thing to remember is the Checkmate 511 compared the standard dose of Ipi, 3 milligrams per kilogram, with this inverted dose in combination with nivolumab. And it found the inverted dose to be lower in toxicity. It would be, a kind of a medical school error to say they were equivalent in efficacy because it was not powered to do that in a 200-some patient study. And we could be making a type 1 error. Small sample size telling us, oh, these two regimens are the same. But if we enrolled 5,000 patients, we might see there are some small but meaningful differences. So the standard is ipilimumab 3 milligrams per kilogram for a lot of reasons. If your toxicity management is, if you don't have a deep roster of subspecialty, if it's all on you to manage these toxicities, and it is perfectly okay to use that inverted regimen, the lower dose of Ipi in the frontline setting.
While you're focusing on BRAF mutated patients, can you share some of the tricks that you use to manage skin toxicity or pyrexia with BRAF and MEK inhibitors?
Oh, yeah, there's a study, COMBI A+ is the pyrexia management algorithm, the pyrexia management study for dabrafenib trametinib. So if you end up encountering some toxicity with fever, with photosensitivity, there's a nice algorithm there that might be worth looking at, and you can also get it from the drug manufacturer, the algorithm. But essentially, it it's drug holidays, right? Now, my issue with drug holidays is that you're taking away drug when you should be keeping it at steady state in the body. The other issue is taking it away and reintroducing it just reintroduces typically the side effect. It's not that you've really done anything to sensitize the body. So the other thing you can do is fairly aggressive use of antipyrexia agents for the first 2 weeks. You can also start the dose lower and build it up over the course of 1 to 2 weeks. So it's just not a watershed of pills in the body. For skin toxicity, low dose of prednisone should be a last resort, maybe 5 milligrams or less, but it can be used to mitigate the skin toxicity without, we hope, impacting an immune response. And you can also use topical Voltaren gel, topical compounding formulations if you get things like erythema nodosum, which can be these painful BRAF nodules.
And that, while we're covering this, the other question that we tend to run into in the community, who should we use anti-LAG-3 combinations for over CTLA-4 or single agent IO or BRAF MEK inhibitors? So who's the right patient that I should be thinking about that?
Yeah, so obviously Nivo-Rela Opdualag is approved in the frontline metastatic setting with an improvement in PFS, but did not meet hierarchical improvement in OS, so we really shouldn't even talk about objective response rate then in that study. But this is also, it goes back to this idea of if you feel like somebody needs combination therapy, maybe based on rising LDH or burden of disease, but you really don't feel like they can tolerate the toxicity of the ipilimumab component, do you feel that they do need doublet, then this would be a situation to consider Nivo-Rela. I think what we're trying to figure out is, could you start with a dose or two of single agent PD-1, and if you clinically assess that LDH is climbing, or you don't feel, at the 6 week or 8 week mark, the scan is showing you what you were hoping to see, which was an early hint of efficacy, maybe then you could add the Nivo-Rela there, instead of sort of saying they must have progression before I switch treatment, or I'll start them right off the bat and then, I've got myocarditis and adrenal insufficiency to handle, because it's still a combination therapy with toxicity. Technically, there's a frontline triplet approved, but nobody uses it. And actually, when you look at NCCN, you can't even find it listed there. And so really it has fallen out of favor. NCCN obviously has the bias of all these academics saying, no, but we don't use it. But it's approved. It's not like the community couldn't use it.
Yeah.
So one of the things I think we need to stay tuned for is that's this idea of PFS2 or total PFS. Sakombit sort of described this. Because if all the triplet studies get you 15 to 16 months PFS, great. So that's your first PFS. So what do you do next? If that next treatment gets you 6 months or 9 months, now you're up to 22 or 25 months. Is that what total PFS 1 and 2 is getting you with Sakombit? I don't know. If it's not, but then of course we've got the toxicity issues, and then we're going to have to be really comfortable with toxicity management when we start doing triplets. And we have to clarify what we mean by triplet. It's BRAF MEK PD-1.
PD-1.
Well, it's going to be interesting in what one is going to use second line in that case.
Yeah. See, if you did BRAF MEK PD-1 or the Vemcobiatezolizumab PD-L1, arguably you still have Ipi-Nivo to touch. Arguably you still have Opdualag. So it's not exact. I think people feel like, you've used everything, but now we're getting to the point where we haven't exactly. Yeah.
No, this is getting complicated, but thankfully that's a good thing for our patients.
Thanks for covering so many pearls today with us, Sapna. Thank you so much for taking the time to join us today and going over the current treatment landscape for melanoma. For our listeners, stay with us for a recap. For a recap with Dr. Patel, in this discussion, we have covered the current standard of care treatment for melanoma, starting from early stage and then all the way to metastatic settings where the treatment is with palliative intent.
With Dr. Patel, we've discussed role of surgery and then adjuvant immunotherapy for early stages. For stage 3 or for resectable disease, we've also covered the role of neoadjuvant or perioperative pembrolizumab followed by surgery and then continuing with pembrolizumab thereafter.
In metastatic settings, checking and then targeting BRAF mutation is important. Even if you have BRAF mutation, this disease can be responsive to immunotherapy. Getting comfortable with managing toxicities for BRAF and MEK inhibitors and immune-mediated toxicities is extremely important. Tune in again to stay up to date with current standard of care, treatment options, and practice-changing data with us, the Oncology Brothers.